Ad time. And find out why so many people say, I got my job to the New York Times. Really? What did you do? I think the people. Ooh, the New York Times. There's a strange phenomenon occurring in space.
What they don't do is tell you about the activity of the man's disease as he walks around in everyday life, as he is active in the environment where he is going to get his coronary events. And that added information turns out to be very rich and full. If you ask them to wear a Holter monitor, you see that they're having many more ischemic events than chest pain, that the ischemic events are occurring under different circumstances, and it gives you a different picture of ischemic heart disease activity. And you would have thought that most ischemic events happen when they're running upstairs and taking a strenuous effort at something, but that's not so. So the first piece of information was negative in a sense and puzzling, because we're used to looking at ischemia on a treadmill where they're huffing and puffing and getting their heart rate up, etc. We looked further in the diaries to find that most of the ischemic events occur while they are involved in some form of mental arousal. In fact, about 77% of events. In one study that we did, and in a confirmatory study, about 73% of events happen while people are engaged in conversations, telephone calls, office work, driving motor cars. So our attention is now focusing on the narrowed proximal coronary arteries.
My personal interest was really to relate the biology of atherosclerosis to the observations made at the clinical level, which were that the recent observation that vasomotion indeed is important, and that vasomotion occurs usually in those areas that are involved by atherosclerosis. And evidence has been accumulating over the last several years that endothelium may be dysfunctional in its vasodilator capacity in patients with coronary artery disease.
Dr. Elizabeth Nabel, who has been doing this work here at the Brigham and Women's Hospital, has been looking in great detail at the reaction of the artery in relation to whether there's atherosclerosis present or not. Here we are.
Here's that third septal.
Third septal.
And here's where the branch comes off. In analyzing high-quality angiographic pictures in orthogonal views, we will ask the computer to compute for us the coronary artery diameter. Plus minus 0.02.
And what we found, in fact, is that the narrowed coronary artery is underestimated at arteriography. Nitroglycerin will reliably produce dilation of epicardial coronary arteries, and when you dilate these stenoses, you produce important changes in resistance in those vessels, and I think it matters a lot. They also reduce preload ventricular volume and wall stress. That's important too, but you know, the reason why I think they work so well is because they affect the two systems that play an important role in producing the ischemia in the first place. I think that during exercise, cold stimulation or mental arousal, you get both constriction of epicardial arteries and an increase in demand. And both of those are going to trigger ischemia. They upset the relationship between supply and demand.
So nitrates seem to offer a whole stack of advantages. The only problem, which arose more and more within the last years, is that all these advantages disappear if you prescribe a drug regimen which causes constant plasma levels. If you're doing drug studies, you have first to be sure that the myocardial ischemia you look at is reproducible. And therefore, we are looking only at patients who have reproducible myocardial ischemia demonstrated by objective means, always at the same exercise levels. We choose to estimate, in addition to the ST segment, the radionuclide ventriculography, because the ultimate goal is to treat the function of the heart of the patient with an anti-ischemic drug, that the impairment of the wall motion is abolished. Let me just show you an example of a patient here on this screen. This is a radionuclide ventriculogram. At the left, you see the left ventricle during exercise develops an akinesia in the apical inferior part of the heart. On the right-hand side, you see the same patient at the identical workload, but 2 hours after the ingestion of isosorbide dinitrate. And as you can see, the sign of myocardial ischemia, the regional wall motion abnormality, diminished or completely abolished. 2 weeks later, the heart did not respond in the same beneficial way as it did at the first day. In the meanwhile, the patient has ingested the tablet in the morning and in the evening as we have prescribed it, and this is a sign of tolerance development, of a considerable attenuation of the initially beneficial effects of the nitrate, which are due to the fact that the patient exactly did what we wanted him to do. On the other hand, the other group, who has ingested the tablet at 8 a.m. and 2 p.m., the anti-ischemic effects were unattenuated, and this was the reason why we came to the conclusion that to prevent nitrate tolerance development, it may be recommendable to prescribe a once daily ingestion of a high single dosage or twice daily regimen, but not morning evening, but morning and the early afternoon, which also guarantees changing plasma levels. Then the anti-ischemic effects are maintained. Okay? In our studies, we only looked at exercise-induced ischemia because if you look at drug effects, you can only look at reproducible exercise-inducible ischemia. But there's more and more evidence that myocardial ischemia changes spontaneously during the day. What we want is to protect the patient during the day, but at night, the nitrate plasma levels have to fall down to guarantee the full responsiveness of the anti-ischemic effects on the other day.
Keine Luftnot in der Brust, Schmerzen irgendwo im Bruchgefühl.
And that group, who had shown an attenuation of the effects, the plasma levels were quite constant. The mononitrate plasma level, the main metabolite of the dinitrate, did not fall below about 380 nanograms per milliliters. But in the other group, who has shown no attenuation, in that group the plasma levels dropped to below 100 nanograms.
Ja. Sie können da gut hinschauen hier, ja? Das ist der Zeiger senkrecht.
A lot of people ask me, it's very interesting about the stuff with nitrate tolerance, but can you please explain to me why I have never seen this in my own clinical practice? I think the explanation is quite simple, because nitrate tolerance occurs only if the patient really ingests the tablets. If he makes his own omissions each Sunday or each Monday, not to take tablets, or he forgets at home and goes on vacation, then he will never feel about the problems of nitrate tolerance. But the clinical relevance of the problem with nitrate tolerance arose when we forced the patient to 100% compliance. And this was achieved with the nitrate patches. The patch gives the patient no choice whether he has constant or changing plasma levels. The patches forces the patient to have constant plasma levels. And this explains why so many critical studies arose within the last years which have detected the problem of nitrate tolerance with the patches.
Schmerzen haben Sie nicht im Brustbein oder im Hals irgendwas?
For most patients who have coronary artery disease and angina, the angina pectoris is used to assess the activity of their disease as an outpatient.
Nur wieder schnaufen. Schön weitermachen, nicht aufhören. Keine Schmerzen, tiefe ST-Senkung.
The man complains of more pain, he requires a modification of treatment. If the man has relief of pain, most physicians are happy. Now, that may be wrong.
Kannst aufhören. Gut?
By analyzing the ischemic activity in Holter tapes in our patients with coronary disease, we've learnt new features, such as the fact, firstly, that most of the episodes of ischemia are asymptomatic. Secondly, the events are surprisingly prolonged, which make us worry about damage to the myocardium. Thirdly, that they are not set off by increases in heart rate that could easily allow us to blame exercise. And lastly, that there's a very important circadian rhythm in these ischemic events. Patients are having most of the events shortly after they get up in the morning and in the first 4 to 6 waking hours of the day, at exactly the same time as the peak occurrence of myocardial infarction and sudden death. And that has important implications for the way we administer anti-anginal drugs. I think the important message for the practitioner is that the relief of chest pain doesn't necessarily mean that there is relief of ischemia, and they may need further protection. So we've learnt a lot from haltering people out of hospital, and maybe, just maybe, it is a useful way to screen certain people who are at high risk. And just maybe also it's an important way to follow therapy if the aim is to control ischemia as well as pain.